Hi, thank you for joining us for our Facebook Live Q&A discussion. We're joined today by Dr. Daniel McKenna, bariatric surgeon at Aurora BayCare Medical Center, to discuss what you need to know about bariatric surgery, including innovations in surgical procedures and who makes a good candidate, and so much more. So thank you for talking with us, Dr. McKenna.
Well, it's my pleasure. And as you know, I'm Dan McKenna. I'm one of the bariatric surgeons with Aurora BayCare Medical Center. Dr. Pierce is the other one. And many of you may see our names as you attend seminars or inquire about bariatric surgery.
Perfect. Before we get started, I want to ensure everyone that we're being safe. We're taking precautions today to remain socially distanced. Obviously, we're wearing masks. If you have questions about bariatric surgery, please ask them in the comments below. We'll do our best to answer your questions today in real time. If we run out of time, though, don't worry. We'll continue to respond online after the broadcast has concluded. So let's go ahead and get started. I want to start basically by just addressing the statistics around obesity in America. Can you quantify that problem for us?
Sure. So when we look at obesity in the United States, it is a growing problem. We obviously have a huge issue with it presently, but over the last 25 years, we've seen exponential growth in the percentage of Americans that are obese. Right now, estimates are that between 30 to 40% of Americans in most states are obese, and that rate is climbing. We are seeing issues with childhood obesity, which means that this rate will probably get to be about 50% within the next 20 years.
Wow. And are you seeing it, you mentioned children, but are you seeing it in all ages, genders? Are there any one demographic that's affected more than others?
No, certainly we see different outcomes when it comes to weight loss or weight gain just based on gender, but it affects men and women equally. We do see that women tend to seek bariatric surgery more frequently than men. The big thing is that men usually sort of picture themselves as just being big and burly with their beer belly, whereas women feel that they need to lose weight from a cosmetic standpoint.
Absolutely. So let's talk a little bit about what that means for people. And obesity obviously contributes to health conditions, other health conditions. Can you elaborate on what that affects as far as a person's health?
It affects everything. So the patient that is morbidly obese ages faster, and that's what we see when it comes to comorbidities. They have higher incidences of type 2 diabetes, high blood pressure, sleep apnea, high cholesterol, gastroesophageal reflux disease. They're more likely to form hernias. They are more likely to have bad joints, bad backs, and they're also more likely to have chronic inflammatory conditions.
Speaking of inflammatory conditions, I know the big topic right now is obviously COVID-19. Can you talk a little bit about how obesity may affect that?
Sure. So, I mean, obviously the biggest topic in the world right now is COVID-19. And when we look at patients who have mortality from COVID-19, obesity is an independent risk factor for mortality, not related to diabetes, high blood pressure, or anything else, but just being obese is an independent risk factor for mortality, and that is very concerning. The reason that is because of likely that there's a higher amount of inflammation in those patients that then compromises their ability to recover from COVID.
Very interesting. In addition to maybe personal effects of obesity on other healthcare conditions, it also affects the system and the costs and everything else. Can you talk a little bit about that and how it affects maybe the health of our communities in general?
Sure. So, I mean, if you look at healthcare expenditures, a large percentage of our money is going towards obesity-related conditions, and that, you know, the elimination of obesity, whether it's through weight loss measures, community outreach, bariatric surgery, has been shown to reduce the costs over time. The issue, of course, is that insurance often doesn't want to pay for those measures, whether it's surgery or medications, even though it may reduce their cost over the course of years.
Interesting. So let's talk about bariatric surgery in general. Why should someone consider bariatric surgery as a viable weight loss option, maybe for these conditions or just weight loss?
So I think before we even get into bariatric surgery, it's very difficult for people to visualize what happens when they go on a diet. I think we've all experienced that when you start to lose weight, you get really, really hungry. And that hunger overwhelms your system to the point where you probably eat more of that diet that you're supposed to be following than you really should. That happens because the body is in a mode in which it wants to preserve itself. So the hormone that does that is leptin, which is a hormone that the body fat produces to suppress appetite. So if your body fat level goes down, then the hormone that's supposed to suppress appetite goes down as well, so then your appetite will increase. And that's what really makes people struggle when they lose 20 or 30 pounds and they kind of reach that plateau and then give up and all the weight goes back on. What is really interesting is that bariatric surgery takes away hunger. Yes, it'll take away your ability to eat as much as you used to, but it will independently take away hunger through some hormonal mechanisms. And if we do the education beforehand to help people, we really see substantial amount of weight loss.
Yeah, and we're going to talk about that too, because I know it's sort of a journey that patients actually go on. But are there certain criteria that make a person a good candidate for bariatric surgery?
Yeah, so I mean, in general, since 1991, the National Institute of Health has used these criteria. Simply put, it's that if your body mass index is over 35 kilograms per meter squared, and you have diabetes, high blood pressure, sleep apnea, high cholesterol, you qualify for bariatric surgery. But if you don't have those comorbidities and you do have a BMI over 40, you also qualify. But it's more than just that. We don't want to just say everybody who has that should have bariatric surgery. So we want people that are willing to change. This is a big change for people. They're going to have to eat healthier. They have to be willing to come and attend appointments and visits and consults. And we also want to make sure, obviously, they're healthy enough for bariatric surgery. So that's part of the assessment as people go through the process.
Interesting. If you're just joining us, I'm here with Dr. Daniel McKenna, bariatric surgeon with Aurora BayCare Medical Center. We're discussing bariatric surgery. If you do have questions about the surgery or anything related to bariatric surgery, please feel free to ask them in the comments below. We're going to do our best to answer your questions today in real time. So I want to talk about some of the innovations in bariatric surgery, because obviously the surgery has been around for a while, but there's been a lot of changes where people might be surprised that it doesn't look like it used to. Can you talk about the procedures that you offer?
Sure. Like anything, bariatric surgery has a very long history. It was initially going to be an operation that you did on the super obese and basically bypass all their intestine, and there were a lot of problems with that. And they went to stapling procedures where they just stapled the stomach off, and those failed quite a bit. So in the last 30 to 40 years, there's been a lot of changes. Obviously, we don't do a lot of bands anymore. Those were done in the early 2000s and didn't work as well. What we realize is that we have to affect the hormonal status of the patient, meaning that we have to do something to make it so that they're not hungry, so that they can follow the dietary changes, and to make that easier as they go through the process. The gastric bypass has been around for quite a long time, but obviously that and the sleeve gastrectomy are the two operations that are most frequently done. There's a third that's called the duodenal switch that's done a little bit less frequently. The big thing when it comes to innovations are that we now do every operation with little incisions, whether that's laparoscopic or robotic. And the hospital length of stay has changed from 2 weeks back in the 1980s to 1 day. And most people are back to work and their normal life within about 2 to 3 weeks.
Yeah, that's a big difference. And can you talk about maybe some of the other differences between the procedures?
Sure. So I mean, there's two kind of components when it comes to how we help people lose weight. One is to restrict how much they can eat. The second is to limit how much they can absorb of what they eat. So the gastric bypass limits a little bit about how much you can eat by dividing the stomach and making it into a smaller pouch, and then bypassing the first part of the intestine, so that food is just not going to be absorbed in that first few feet of intestine. And that operation has both components. The sleeve gastrectomy has really is essentially turning the stomach into a long, narrow tube, like a banana. And that in itself will take away appetite, but you're not really getting the malabsorption, meaning you're still absorbing food like you normally would. Mm-hmm. The duodenal switch is one that does a sleeve, that first part where we make the stomach into a banana, but then we bypass all but about 100 centimeters of the small intestine. So that has a lot of weight loss, but a lot of malnutrition associated with it as well.
So that's a good point. Is there a procedure that you would recommend specifically for a certain type of patient, or how do you decide what's best for people coming in?
A lot of it depends on just the individual patients, and we want to look at what their risks are. We also want to look at what surgeries they've had in the past, what their medical comorbidities are, and come up with an individualized plan.
Very cool. You talked about it a little too, but I want to maybe stress that some. These patients are inpatients and they stay in the hospital. How long? What is the recovery time like for most patients? Obviously, it's...
So everybody's a little bit different, but if somebody isn't at baseline very ill and they have not a lot of narcotic dependence, then we would expect that for most people they're back to work in 10 to 14 days. And they usually, by 2 weeks, say that they feel like they have more energy than they did before surgery.
Wow. And this is certainly a first step in their process. So you're meeting with these patients regularly. Can you talk about how surgery is really a lifestyle change for these patients and maybe what that entails?
Sure. So I mean, when we look at people who really do well with bariatric surgery, there's a willingness to change. And what we're really trying to assess is that that's present. Now, the reason isn't because we want to be punitive or punish you for not wanting to change, just because you have really one great shot at success. So as we go through the process, we're continually assessing how well they can comply with the diet. Do they understand what we're asking them to do? Are they coming to follow-up visits? And making sure that when we do the surgery that we're not harming them, that we're actually helping them and making them successful.
Mm-hmm. Yeah, and we'll get into those details too in just a little bit, but obviously there's some lifelong commitments after bariatric surgery. Can you talk a little bit about what that means for these patients?
Sure.
It's not just surgery and done. There's certainly some lifestyle changes.
Well, I mean, we've all seen people who went to Mexico and had bariatric surgery or had bariatric surgery with surgeons years ago who didn't do any education, and they've regained all the weight. So the reason that bariatric surgery works is that it's a lifestyle change, and so we expect that people will eat normal food. They're going to be focused on eating protein, vegetables, and dairy. We really restrict how much people eat as far as carbohydrates. So not just sugar and cookies and crackers, but also noodles and bread and everything else. Now, I've had people tell me that that's not livable, and the problem is that what they're doing right now isn't really livable either.
Mm-hmm.
So it is important to realize that what seems like it's very difficult becomes very easy as you get into the habits of it. But I think that the other component is that we really want people to follow up because, sometimes, you become depressed or you have issues and you eat like you shouldn't, you start putting weight back on. That's all fixable when it's just a short period of time. It's just that coming back for follow-up visits has some accountability, but also helps us make those changes before they've regained the weight or they've created more problems for themselves. But it's a lifelong commitment, but it is one that ultimately leads to such an improvement in quality of life that most people don't have a difficult time wanting to come back.
Yeah, and I want to talk about that too because you've seen some pretty incredible things with your bariatric patients. Can you talk about maybe some of the health outcomes or the changes that you've seen, witnessed, basically?
Sure. No, I mean, I think when we look at everything, so quality of life in general, we have people that were unable to work that are now able to work. We have people that had chronic pain that no longer have pain. People with acid reflux that are now able to eat and not wake up in the middle of the night with food or fluid in their mouth. The most amazing thing, though, is that when we look at diabetes, high blood pressure, sleep apnea, that we see such rapid remission of those conditions that people are sleeping better, they're taking a lot less medications, and they're more active than they used to be. Mm-hmm. It doesn't just affect usually the patient either. It's that the whole family sort of has some change because of it. And we often say that there's a halo effect with bariatric surgery, that many of the family members lose weight and become healthier as well.
Mm-hmm. And not to mention just the extra mobility and energy, the things that they can do with their family member who maybe had it as well.
And as I mentioned, I mean, when we look at that chronic inflammation that happens because of obesity, people will, even in the first month, notice that their hips and their knees and their back hurt so much less just because their inflammation is going down, that they're able to be much more active, and then that helps obviously with weight loss as well.
Incredible. Some really great information here. If you're just joining us, I'm here with Dr. Daniel McKenna, bariatric surgeon at Aurora BayCare Medical Center. Today we're discussing bariatric surgery, and if you do have questions, please feel free to ask those in the comments. We'll do our best to answer them today in real time. So we've talked about sort of the options for patients, and I'm wondering now what maybe the next step is. If I'm somebody who's sitting at home who might be interested in learning more about these procedures and if it's right for me, what should I do?
So usually people will either inquire through the online or they will call. And the first step is that we do an online seminar. We used to do a lot of these in person, but obviously with some of the COVID changes, we're doing those less frequently. The online seminar goes over all the kind of nuts and bolts about what bariatric surgery is, what will happen through the process, what the operations are, what the outcomes are. Certainly listening to me talk for a period of time will be very similar to that, but that's the first step. And then if they're interested after they do the seminar, then we have them set up a consultation. And most of the consultations are usually done with Laura Gintner, who's our physician assistant. And Laura is phenomenal. She is made for this role. She has a background in primary care, so she understands how you manage diabetes, high blood pressure, all these things, and is very empathetic and very good at kind of listening to people and helping them through this journey.
Wonderful. We'll go ahead and post the link to that online seminar in the comments too, so you have that. You talked about Laura. I want to talk about the team that you have, because it is really sort of all-encompassing, and you're working with primary care physicians and making sure that these patients are kind of handheld the whole way through this process. Can you talk about that?
Sure. So, bariatric surgery is only one component of having successful management of obesity. We have Laura, who is really the person that you see most frequently, and then obviously Dr. Pierce and I. But other than that, we also have Becky Kuhn, who's our clinical nurse coordinator. She's phenomenal in that role. She's been here for longer than I have. She is responsible for helping patients through the process, making sure that everything that they need to do is accomplished. She's also responsible for the education of the nursing staff in the hospital, maintaining our center of excellence. She's in charge from an administrative standpoint. Then there's also Amy, who's our medical assistant, and Amy does a marvelous job at managing patients, troubleshooting problems, answering phone calls. We have a team of dietitians that work with us. The dietitians see people regularly throughout the process, and their information and what they get across to our patients is every bit as important, probably more important than what we do, because without the diet being right, nothing that we do really matters. We also have both a psychologist and a psychiatrist that work with us. The psychologist does a lot of the initial consultation, because everybody that goes through the process has a consultation with a psychologist. But some of the therapy and all that is done by the other provider, who is absolutely phenomenal. We have a great team, and obviously there's a number of nurses and everybody else that answers questions that come in through our general surgery office as well.
I think that's a great point, and I think you illustrated it well. There really is sort of this all-encompassing team that's going to help people through this process. It's not going to be a one-and-done type thing. So.
Right. And that's what they used to do. I mean, it used to be that you had the surgery, they saw you once or twice post-operatively, and then that was it. And in the last probably 10 to 15 years, that's been a complete shift away from that across the United States.
And you've probably seen more success.
Yeah, so now obviously you see much more success with that.
Absolutely. And so they don't need a referral or anything. Once they do the seminar, that kind of thing, they can call the office and set up that consultation?
If they want to get a referral, that's fine, but certainly we see plenty of people who are self-referred for obesity surgery.
Great. I do want to get into some of the detail. I know we covered it a little bit, but what can sort of people expect? They've done the seminar. What is the next step for them? Because this isn't an overnight process. They're not going to get in for a procedure 2 weeks after they do that.
So, I mean, the normal process is that they do the consultation, and then they will see the dietitian and the psychologist. We really put them through that to make sure that everything is right before we do surgery. So they have to be cleared by them, that they understand the diet, they are mentally ready for surgery before we move forward. Some of the time that's required is dictated by insurance as well, so that can be 3 to 6 months of what's called supervised weight loss, which means coming in once a month and talking to the dietitian and all that. But that part we can't control. So there's no emergency when it comes to you need to have bariatric surgery sooner. If your insurance dictates 3 months or 6 months, that's just what has to be. I do think there's a benefit to having a period of reflection and seeing if this is something you really want to do with the rest of your life. So I think 3 months is reasonable, but 6 months is more punitive, where they're just hoping you quit and drop out and they don't have to pay for it. But that is, I mean, that is what the role of Becky is to help people through that process and make sure that we have everything that we need to do. There's a number of things that we provide that are educational through the whole process, right? So we have them doing videos and online modules and things like that to really make sure that our patients understand what it is that we're doing and also understand what the path will be like after they have surgery.
Mm-hmm. Yeah, and that understanding seems to be kind of a common trend, so that you're really setting them up for success.
Yep, absolutely. Yeah, I mean, without that, you're on your own, and obviously it just leads people back to doing the same thing they've done before, which won't probably work.
Mm-hmm. Great. Is there anything else that you'd like to add?
No.
I think this is a great conversation. Again, we're going to post the link to the online seminar. If you are interested, you can continue to ask questions here online. We'll go ahead and answer those after the live broadcast. Thanks for spending some time with us today, Dr. McKenna. I think this was really great.
Yeah, it's my pleasure. It was a great time.
So Dr. McKenna is a bariatric surgeon at Aurora BayCare Medical Center. He currently sees patients in Green Bay, Marinette, and Kaukauna. If you have additional questions, please feel free to ask them in the comments. As I mentioned, we'll continue to answer those online. If you want to learn more about BayCare Clinic, bariatric surgery, or request an appointment, you can visit baycare.net. Thanks so much for joining us.
Thank you.